Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you very much. This is, in fact, a repeat of my last talk. There'll be a little deja vu if you were there a few months ago. And I'm going to go through this with a thought of how well did I do in predicting? And I think in some places I did well, and in some places I'm not so sure. So my disclosures, the main thing is that since there are no medications that are FDA approved for use specifically in post-exposure prophylaxis, all of this talk is discussion of non-FDA approved off-label strategies for use as HIV prevention. This is the funding disclaimer. And then this is what I predicted on March 6th when I gave that talk. I said I thought there'd be more discussion about indications for nPEP, including a newer emphasis on the relative urgency of provision of post-exposure prophylaxis. I knew that we'd have a change in the first-line 3-drug regimens. I thought there would be changes in laboratory testing along with our new HIV testing and monitoring strategies, and I thought we'd see better alignment with the PrEP guidelines and the PEP to PrEP transition. So let's see how I did. The first two are just the image, so you can have the reference. You can see that I'm not lying, that it came out just this month. This, if you read none of the, 90 pages of the guidelines, is box one. I'm not going to read this to you. This is what is new in the guidelines, but we'll go through this in detail. So first, I've said that I thought there would be new conversation about the indications for nPEP and this new emphasis on the urgency of nPEP. And I think we've always said that post-exposure prophylaxis should be started within 72 hours of the exposure. Again, today I'm talking about post-exposure prophylaxis, so taking HIV medicines after someone has been exposed. Typically, I'm talking about pre-exposure prophylaxis, where someone is taking medicines and then is sort of having repeated exposure. So again, today we're talking about post-exposure prophylaxis. So recommendations, again, had always been within 72 hours, and the data haven't really changed in terms of what we know about the efficacy. Most of this is from animal models and studies that are quite old at this point. But the guidelines are really sort of emphasizing that this is as soon as possible. And so it remains within 72 hours. And so one thing that has changed that I have there in bold is that someone who is within 72 hours, who has an exposure with substantial risk, which they go on to define, and the source is known to be HIV positive, new this time is this without viral suppression or their suppression is unknown, that nPEP is recommended. And again, this sentence hasn't changed except for that comment about viral suppression or suppression is unknown. Basically because what we're recognizing is with U equals U or undetectable equals untransmittable, that someone who is known to be HIV positive, is on medicines, who has been virally suppressed with a viral load of under 200 copies per milliliter can essentially not transmit. So this is the first time in the CDC HHS guidelines that they are specifying this higher level when we know that someone is HIV positive and their viral load is either detectable or we don't know whether their viral load is undetectable. In a case-by-case basis, we're going to investigate someone who is within 72 hours. There is still a substantial risk for HIV transmission with the exposure, and we don't know the HIV status of that potential source patient. Again, nPEP not specifically recommended, but I think most of us would probably prescribe PEP in this circumstance. And then they go on to say specifically, again, not different from the last guidelines, which were from 2016, that if there's no substantial risk, that PEP is not recommended. Again, I mentioned earlier that there is this new emphasis on urgency. So there are statements that say initiate nPEP as soon as possible, as well as this statement that says, really trying to reframe PEP for us, that exposure to HIV is a medical emergency. So If you're one of those people who likes seeing things as figures, if you're a more visual person, this is the image that is replacing the old figure from the old guidelines, where you can walk down in this algorithm to decide whether PEP is indicated. So it has someone have a possible sexual exposure. The next slide is going to be for folks who have a potential needle stick exposure. So this one for sexual exposure, yes. Is it within 72 hours? Yes. And so what you can see is they've gone through and defined what a substantial risk could be. So for oral genital contact without a condom, they're saying nPEP is not routinely recommended, although, again, it leaves the window open for you to have that conversation and decide whether to prescribe. For if there is a condom use, I'm going to move over to the far right. That is, if the condom is intact, it hasn't broken, it stayed on the entire time, nPEP, again, not recommended. And so let's work down through the middle of this. So anal or vaginal intercourse without a condom. This algorithm now incorporates whether someone is taking PrEP. So someone who is taking PrEP as recommended daily use, and for the CDC, they say that is more than 4 doses for folks who are cisgender men and 6 to 7 doses for everyone else. If they are taking it as recommended, that is not an indication for post-exposure prophylaxis. That is exactly why people are taking PrEP, because they know they are getting exposed. But if you have any uncertainty about whether or not the person has been taking PrEP as recommended, then you would probably want to talk about whether PEP is indicated. Okay, I'm going to move down from here. So if the person is on PrEP and not taking it, then we assess whether or not the source is known to be HIV positive. If the source is unknown, again, we're going to talk about that case by case. If the source is known to be HIV positive, here we in the algorithm include whether or not they have sustained viral suppression. And then you go into whether or not nPEP is recommended or not routinely. The other thing that's new in this algorithm is this emphasis on considering PrEP after the end of PEP. So there was a lovely figure like this in the HIV curriculum. I think you have a more complicated figure that to incorporate in the future for the HIV curriculum and the PrEP curriculum, but I really love the detail in this figure. And again, this is the one for someone who has potentially been exposed through injection drug use. And it is pretty similar, including whether or not your source has known detectable viral load or unknown. And interestingly, although the U=U data comes from sexual transmission, it still includes this, although if the source has sustained viral suppression, we're going into case-by-case determination rather than nPEP not being recommended, which it is not recommended for sexual exposure. So super complicated. Happy to talk about this more and review these in detail after the talk. The change in 3-drug regimens are really similar to what I predicted. From 2016 is what I have there on top. The recommended medications were FTC, emtricitabine plus tenofovir, disoproxil fumarate plus either raltegravir or dolutegravir. Now the preferred regimens are either single pill bictegravir, emtricitabine, tenofovir, alafenamide, or dolutegravir plus either TAF or TDF plus either FTC or 3TC, which is lamivudine. There are notes about, I have not included all of the potential permutations about whether someone is pregnant, whether comorbid conditions, all of those details are well outlined in the new guidelines. So consider that, as well as the potential resistance. If the source is known to be positive and has HIV drug resistance, then you might consider an alternative regimen. The other thing that I thought was interesting is that there is a statement that says, because as we've talked about before, even though the recommended course is 28 days, pharmacies won't break the bottle and therefore might not get reimbursed for the full 30 pills. They recommend considering prescribing a 30-day course, but telling the patient only to take 28 days. I'm going to review what the laboratory testing guidelines are, and I think there will be a lot more conversation that we'll have over the next few months. There's a paper about some of the HIV testing recommendations in PrEP, and I think we'll see more comment about some of these recommendations as we move forward. And I expect you'll hear me talk about HIV testing in a future talk. But I just wanted to quickly tell you what these new guidelines say. So the baseline testing is what's recommended is a point of care HIV test or a laboratory antigen antibody HIV test or both. So again, I'm going to say that they say either or both. And then in another place say that even though we're saying this, still a laboratory antigen antibody test is recommended. We can talk about that if you'd like. Oral fluid tests, as with starting PrEP, are not recommended because, again, for their relatively longer window period. And then they recommend adding a HIV nucleic acid test at baseline only if someone has been on long-acting injectable PrEP in the text it says 12 months, in table 3 towards the end it says 6 months, so 6 to 12 months. I'd probably err on the side of conservative and do it if the last 12 months. And then the interval for testing for interim HIV testing hasn't changed, but they've added NAT. So once someone has an exposure, takes 28 days, the recommendation is to do an antigen antibody test either at discontinuation of PEP or 2 weeks later. So 4 to 6 weeks after the last exposure. They say you can skip this visit if someone has been on their PEP, they started it quickly, and they didn't miss any doses. And presumably you might skip it if someone is not going to start PrEP, because then you'd probably do that visit anyway. And then at 12 weeks, so a full 6 to 8 weeks after stopping PEP, there's another recommendation for both an antigen antibody test and a nucleic acid test, and that is considered a definitive test. There's nothing surprising in the other laboratory tests that are recommended. They're recommending at baseline a creatinine, liver function test, hepatitis B as in boy testing, hepatitis C testing only as appropriate to the situation, pregnancy testing if relevant, and bacterial STI testing. They recommend considering presumptive treatment for bacterial STIs, or new here obviously is a recommendation for doxy-PEP if the timing makes sense. Inform the person about signs and symptoms about acute HIV infection, fever, rash, sore throat, muscle aches, joint aches, that flu-like syndrome, just so they come back in for testing if they're having those symptoms, if it's not within the window of their other testing. And then there's very little other follow-up recommended in terms of laboratory. They do want someone to call the patient within 24 hours to confirm that they've picked up their meds and they've tolerated the first 24 hours. And then there's a comment about a retest for STIs if empiric treatment wasn't given and those initial tests are negative. My last thought was that there would be better alignment with the guidelines and PEP to PrEP. There is the reinforcement about that immediate transition to PrEP that might be beneficial for some folks who have repeated or ongoing risk for HIV infection. And then they make a comment about the possibility of false negative HIV tests and the need for ongoing PrEP care and HIV testing. And someone is obviously in these guidelines very concerned about the HIV test results, which I think is why, even though there has been some pushback around NAT for PrEP, why we saw it here again in the PEP guidelines. There are other recommendations that are related to implementation. These are directly from the guidelines. So the first is a comment that people should use a culturally respectful, trauma-informed approach. There are a lot of counseling recommendations that are listed on page 19 about all the information that you should provide during the PEP visit, much of which you're probably already doing. But I just thought it sort of brought me back to the checklist of HIV testing that we used to do 20,000 years ago. But just it's probably worth a review to make sure that people touch those things. They emphasize here that we should be, during PEP visits, providing standard care for other things and not focusing only on PEP, including screening for safety around sexual assault, domestic violence and abuse, sex trafficking, mental health concerns, and substance use disorder. They remark about reporting requirements, and then this new sort of thing that we're talking about PEP in pocket. So the idea that someone who has ongoing risk but may not be interested in taking PrEP might have a prescription for PEP in the future so that they don't need to seek medical attention and can start PEP as soon as possible. We talked a little bit about these alternative things and comments that more research is needed around 2-drug post-exposure prophylaxis, about injectable PEP, as we're going to start to see more injectable prevention medications, alternative durations, again, because most of this is based on old medications and old data in animal models, and then looking at implementation and performance of all of these strategies, tests, and testing intervals.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.